Hello, my name is Dr. Fabiana Lorencatto. I'm the co-director and associate professor of the Centre for Behaviour Change at University College London. And my background is in psychology, and my research focuses on behavioural and implementation science, specifically the application of behavioural science theories, methods, and frameworks to understand what's driving behaviour as a basis for designing interventions to change behaviour. And a lot of my work has focused on healthcare quality improvement, specifically in the area of infection prevention control and antimicrobial stewardship. And I'm delighted to talk to you today about antimicrobial resistance and behaviour change. So the learning objectives for this lecture are really to give you an initial insight into how behavioural science might be relevant to antimicrobial resistance. And the specific learning objectives are to help you develop an understanding of the importance and role that behaviour change plays in contributing to and addressing AMR and digital health, to help you gain an appreciation of maybe some of the challenges and limitations to traditional approaches to designing interventions in the context of antimicrobial resistance to improve antimicrobial stewardship. And then the bulk of the lecture is going to help you get an initial familiarity with some of the basic theories, principles, and methodologies in behavioral science, and how they can be applied to, first of all, specify the behaviors contributing to antimicrobial resistance, understand factors influencing these behaviors, and then using that to select strategies that are more likely to be effective in improving antimicrobial stewardship. And I'll weave in examples from antimicrobial stewardship throughout, and digital health as well. On this slide, there is some suggested pre-readings. I would recommend reading some of these to help give you a bit more of an overview of what I'm going to talk today. And also there's lots more examples that are signposted in these references. So if this is of interest, this would be an initial good starting point to get a good overview and some examples of behavioral science being used in antimicrobial stewardship. So let's get stuck in. So in terms of setting the scene, why should we think about behavior when it comes to antimicrobial resistance? I probably don't need to tell those of you listening to this lecture today about the importance of AMR and what a major global public health threat it is. So if we look at some of the factors contributing to antimicrobial resistance, I quite like this infographic from the WHO, the blue one, which outlines some of the causing factors that contribute to antimicrobial resistance. It includes things like overprescribing of antibiotics in both healthcare and agriculture, poor infection control practices in hospitals and other settings, as well as patient-related factors, such as patients perhaps seeking or requesting antibiotics to treat infections that are not bacterial, and then subsequently not adhering to the course of treatment when they've been prescribed an antibiotic. What do all these things have in common? Well, they are all forms of human behavior: prescribing, seeking medications, adhering to medications, infection control. These are all actions that humans perform. So by definition, they are behaviors. And if we look at national action plans, guidance documents, and strategies that outline plans for tackling AMR and goals, such as the UK National Strategy, they often highlight key targets such as reducing antibiotic use, improving hygiene practices, improving prescription of antimicrobials, and adherence to evidence-based guidelines. So these things I've circled in red. Again, the key thing I want to convey to you here is that using antibiotics, hygiene practices, prescribing, and adhering to guidelines, again, they are all forms of human behavior. You can see where I'm going with this. And just to pivot slightly, because this is a hub on AMR and digital health, a lot of the recent technologies, the exciting technologies being developed to help improve antimicrobial stewardship are digital. So things like clinical decision supports with machine learning algorithms, AI, diagnostics, digital surveillance, and epidemiology. All these digital solutions have great potential to help change some of these behaviors, contributing to AMR. But these solutions will only realize their potential if people actually use these new digital technologies. So again, engaging with digital technologies is also a form of human behavior, and quite a complex one at that. And colleagues of mine that I've referenced at the bottom of the slide have done a lot of work on conceptualizing engagement with digital technologies from a behavioral lens. But again, key thing I want you to take away from this slide is that we can develop tools, but unless people use them, they won't realize their potential. And engagement with digital technologies is a form of human behavior. So the key thing I want you to take from this setting the scene is that human behavior is absolutely central in terms of causing and contributing to antimicrobial resistance developing. And in turn, behavior change is going to be key to help us get out of it, to help us prevent the spread and limit the impact of antimicrobial resistance. And we're not just talking about behavior of individuals. Tackling AMR is going to require a system change. The systems are made up of individuals at different levels of the system, from individual to groups, organizations, and also larger environments such as policymakers. So we need to think about who are the different actors contributing to AMR at different levels of the system, what are their behaviors, and what might be driving those behaviors so we can design more effective interventions. So given the importance of behavior change to AMR, we can think of antimicrobial stewardship programs as a form of behavior change intervention. And on this slide, I've pulled a definition of antimicrobial stewardship, as well as a definition of behavior change interventions. And you can see they have quite overlapping terms and similar definitions. And because AMS is all about improving behaviors contributing to AMR, we need to think about them as a form of behavior change intervention. And therefore, there is potential to draw on behavioral and social science to think about how best might we design antimicrobial stewardship interventions, so draw on that wider expertise in the behavioral sciences to design interventions to change behavior in the context of AMR. However, when we look at traditional approaches to quality improvement and designing quality improvement programs, not just in AMR, this is a general cross-cutting issue we find in implementation science, we see that a lot of interventions to improve the quality and delivery and safety of healthcare have been designed on what has been called the Isligiat principle to designing interventions. This is a term that was coined by Professor Martin Eccles, an early prominent behavioral science and implementation science researcher. And the Isligiat approach to intervention design stands for, it seemed like a good idea at the time. So by that I mean, when we're designing interventions to change behavior in healthcare, we often design something based on no specific rationale. There's a tendency to rush to solution. So to just design an intervention based on hunches, common sense, gut instincts as to what we think needs to change. I mean, we're all human, so we all know what drives behavior, right? Well, not necessarily and not quite. Often there's a tendency to assume that if we just tell people what to do by handing out new guidelines or information or a new campaign, that they will change. But we know, as we'll see later in this lecture, that factors influencing behavior are much more wide-ranging than just knowledge deficits alone. Or that something worked elsewhere or is trendy. So nudge became a very popular trendy strategy. So there's often a tendency to think, oh, I'll use that nudge strategy to try to change something related to AMR. But nudge will only work if it's the right strategy for the right types of influences, and I'll talk about that a lot more. So often when we're designing quality improvement, we have a problem we want to fix, so we just rush to solution without first stopping to think about what is it that actually needs to change. And as I said, this issue is not unique to antimicrobial stewardship. Antimicrobial stewardship is not immune to an Isligiat approach. So there have been reviews over the past decade looking at how antimicrobial stewardship interventions have typically been designed and the extent to which they are drawing on behavioral science. And I think the highlight summary is that they don't make best use of the available expertise and evidence in the behavioral and social sciences. So very few antimicrobial stewardship interventions have an explicit rationale for why they chose that specific strategy to try to improve antimicrobial stewardship. So very much it seemed like a good idea at the time. Very few take into account the behavioral and social influences on antimicrobial use, draw on behavioral theories, models, or frameworks, or incorporate explicit behavior change techniques. So there are some gaps and opportunities there. So why is this a problem? Well, the variable design and delivery of interventions could be contributing to outcomes or lack of effect because perhaps the strategy is not fit for purpose. If we just pluck a strategy out of thin air, it might not actually be addressing what is it that needs to change. If we don't really have transparency around what's in an intervention, it makes it very hard to understand what is it and how it works, which in turn makes it very hard to learn from our successes and failures, and then replicate, implement, or scale up interventions that are found to be successful. So how can we do better? So instead of the "it seemed like a good idea" approach that is often done, such as brainstorming solutions, picking one and putting it out there and hoping it works, we advocate for a stepwise behavioral science-informed approach to designing interventions. So conducting first a behavioral diagnosis to identify what needs to change and understand the problem in depth, and then matching the choice of intervention to that behavioral diagnosis to increase the likelihood that the solution fits the problem, basically. So just like you wouldn't prescribe a medication without first assessing a patient's symptoms and choosing the best choice of medication to fit those symptoms, we should see behavioral intervention design in a similar way. We should choose a solution that best fits the behavioral symptoms, so the barriers and enablers and influencing factors. And this is where the behavioral and social sciences can help. So the behavioral and social sciences are a collection of different disciplines dedicated to scientifically studying human behavior. They include disciplines such as psychology, sociology, anthropology, politics, economics, law, etc. Now, what these disciplines do not offer, and I usually like to have a health warning at this stage, is a magic bullet or a universal solution as to what strategy will work to change all behaviors at every time. Nor would they wish to do this, because a lot of what these disciplines offer are theories, frameworks, and methods for understanding what drives behavior in context. So very important to think about context-specific understanding of behavior and using that to identify how best to most effectively change it. So for the remainder of this lecture, I want to take you through just one behavioral science approach to designing interventions to change behavior, and using examples from antimicrobial stewardship and digital health throughout. Just to emphasize, this is one approach that my center tends to work with. There are lots of different approaches to designing interventions for changing behavior, but they generally follow the same principles and steps. But the reason I also wanted to highlight this approach is because it's also been widely used in the context of antimicrobial stewardship. So I have lots of examples I will signpost you to throughout that you can refer to for some further reading if a particular aspect is of interest. So the behavior change wheel approach was developed out of a recognition, again, that there are lots of frameworks out there, but different frameworks have different emphases, some of them overlap. So it was developed through, in a nutshell, a synthesis and integration of existing approaches to designing behavior change interventions and trying to streamline and simplify to try to make behavioral science theory and evidence more accessible to people from a range of backgrounds beyond some of those academic disciplines I just mentioned. So the behavior change wheel approach to designing interventions generally follows a stepwise theory-based approach, starting with, first of all, defining your problem of interest in behavioral terms. So thinking of the challenge that you're trying to address in order to bring about change in that. Who needs to do what differently, where, and when? What are the key actions and actors? Then moving on to the all-important behavioral diagnosis. So using theory to understand behavior in context and identify the barriers and enablers that need to be targeted for change. And then lastly, considering the broad range of potential intervention strategies and matching your choice of interventions to the findings from your behavioral diagnosis. And there are theories and frameworks and principles that you can use at each stage of the process. So I'm now going to take you through each step in turn briefly, with an example from antimicrobial stewardship and digital health. So, step one, defining the problem in behavioral terms. When we start a quality improvement or behavior change intervention design process, we tend to think in terms of the outcome that we want to achieve. Fair enough, that's a valid starting point. But reduce infection rates or improve infection control, these are not actually behaviors, they are outcomes of behavior. So to bring about a change in these outcomes, we need to take a step backwards and think about what are the actors and actions that underpin and contribute to that outcome so that we can identify which one that we need to target. So for instance, things like hand washing, effective use of protective clothing, cleaning surfaces, maintaining appropriate isolation. These are all distinct behaviors that might contribute to infection rates and infection control. And this importance of defining your problem in behavioral terms is vitally important to antimicrobial stewardship. Antimicrobial stewardship is a sort of umbrella term that is comprised of a complex set of interacting behaviors performed by different actors at different time points in different locations on a continuum. So if we look at here this example of prescribing a medication, the continuum might start when a patient becomes unwell and the patient seeks medical advice or care. So that is a behavior. And then there might be some kind of diagnostic behavior happening to try to identify symptoms and diagnose the condition. And they might have to document things, communicate between teams. And then there will be the processing of samples, blood cultures, and then it will have to be fed back, perhaps checked against guidelines, which will lead to an antibiotic, for instance, being prescribed and making decisions around dose, duration, documenting and communicating those decisions. And then after a specified time period, ideally reviewing, switching, de-escalating antibiotics, etc. All of these different things in bold are different actions or behaviors that might be performed by different people. And this is just an example from a completely different setting. And this is a great paper. I'd really recommend you reading that illustrates this approach. But this is just an attempt to sort of break down the different behaviors contributing to antibiotic prescribing by vet surgeons. So again, you can see a range of different actions in this table. So the reason this is important is because depending on which point in the pathway and which actor in action you focus on, you might end up with a very different product in terms of your final behavior change intervention, because different actors and different actions will be driven by different factors. So we need to be as precise as possible in terms of who, what, where, and when. So action, actor, context, target, time frame, so that we can be much more precise when looking at what are the barriers and enablers, and in turn designing more targeted and focused interventions. It's also really important to help us measure change. So if we want to measure how successful our intervention is, it helps to be precise about whose behavior and what specific behavior we're intervening. And it also helps with replication and scalability. So rather than just saying my antimicrobial stewardship program targeted antibiotic prescribing, which is very behaviorally unspecific, this is an example of how it could be phrased in a much more specific way. So the specific actor, nurse and pharmacist independent prescribers, the action, in what context, so primary care, and for certain patient infection groups, such as upper respiratory tract infections. The thing I want to take away here is the importance of realizing that antimicrobial stewardship is a huge, complex concept, and there are lots of different actions and actors contributing to it. So try to be precise and break down who and which behaviors are we specifically interested in here. And that, from my experience, the subsequent conversations and steps you take and the final intervention you end up with can look quite different depending on what you decide at this stage. So once you have decided on whose and which behaviors you are interested in targeting, the next most important step, in my opinion, is to conduct a behavioral diagnosis to understand behavior and context. So this involves asking yourself, why do people act the way they do? Or in terms of what drives what they currently do and what makes it difficult for them to change what it is they are doing. People aren't always rational. We might think it's straightforward for people to change what they're doing, but the human behavior is complicated. But that doesn't mean we can't simplify that complexity. So this step's about asking yourself, why do people act the way they do, and what would it take to bring about change? So identifying those barriers and enablers and influencing factors on your behavior of interest. So conducting a behavioral diagnosis. And theory can help us with this step. The issue is, we love a theory in behavioral and social science, and there are a lot of theories out there. And again, some of them overlap and have different emphases and areas of focus. So in a bid and effort to try to simplify and streamline, as part of developing the behavior change wheel, we've integrated different models and theories of behavioral science into a simple but comprehensive model of behavior change that hopefully is more accessible to people from a range of different backgrounds. So that model, which some of you may have heard of before, is the COM-B model. And the COM-B model argues that behavior occurs as an interaction between three necessary preconditions. In order for someone to do the behavior of interest, they must have the capability, opportunity, and motivation to do that behavior. So let's break these down. By capability, we mean they must have the psychological and physical ability to do the behavior of interest. So this means they have to have the knowledge, any technical or communication skills. They need to be able to remember to do it, to be able to pay attention, decide when and how to do it, etc. By motivation, we mean sort of, again, a two-layer thing. So there are reflective motivational processes, which are things like conscious processes, such as believing something is important, believing that it will bring about good, so the pros and cons and weighing those up, seeing it as a priority, as relevant to that person's personal identity, and being confident in your ability to do so. But then there's also these more automatic motivational factors, and things like emotion fall under that. So things that might influence what we do at a more subconscious level. So positive and negative emotions, as well as just habit and habitual behavior. So doing things on autopilot, as well as incentives and reinforcers or potential sanctions. And lastly, opportunity is all about how our physical and social environment around us shapes what we do. So physical environment includes things like how our environment is laid out, what resources are available, access to the necessary time, staff, equipment to do something, as well as social influences, which is how people around us influence our behavior. So social norms, culture, both within our immediate environment and broader cultural environments such as countries, religions, but it's also how we interact as peers, colleagues, but with our family, so patient-doctor interaction. All these things fall within social opportunity. So when we're conducting a behavioral diagnosis, what we're trying to do is explore the role that capability, opportunity, motivation play in influencing your behavior of interest. So we can use a range of methods to do this. Often qualitative methods are used, such as interviews, focus groups, ethnographic observations, where we might ask people a question related to each aspect of capability, opportunity, motivation, or we might do surveys as well, tapping into each of those. And, sometimes we might not be able to do a full-blown research study, and that's fine. You could also just get key stakeholders around a table and have a slightly longer meeting and just work through each aspect of capability, opportunity, and motivation and ask yourselves, what role is this factor playing in influencing my behavior of interest? So in the context of AMR, there's some boxes in blue on the side of the screen. And here's just some example questions you could ask to tap into each of those domains in the context of AMR. So within capability, we could ask about, do people understand what AMR is, know what antibiotics can and cannot treat? Are they aware of recommendations and guidelines around use of antimicrobials, procedures for diagnosing and treating infections? In terms of motivation, do they see it as their responsibility to try to improve use of antibiotics? Will it make a difference? Will improving the use of antimicrobials or other behaviors actually impact on AMR? Pros and cons, balancing uncertainties and emotions around that, and also competing priorities. When we're talking about behavior change in the context of healthcare, and also in people's day-to-day lives, so patient behaviors, there's lots of other competing factors and priorities. So where does AMR sit as a priority? And opportunity. So again, do people have the time, resources to do any changes associated with the behavior you're targeting? How do colleagues and people around influence that, and teamwork and communication and dynamics, etc.? So our role when doing a behavioral diagnosis is to be a detective and to explore to what extent each of these factors might influence the behavior of interest. And not all of these might come out as important factors, but we want to at least rule them out. So rather than make assumptions that people don't do something because they don't know that they need to, so it's a capability barrier, we need to first of all explore whether there is a knowledge gap before we run to educational strategies. So what we're trying to do here is identify what exactly is it that's stopping or helping people to do the behavior, so we can then subsequently match the choice of intervention. So on this slide, I've provided some screenshots that are essentially references to open access publications that illustrate the application of COMBI to do a behavioral diagnosis for different behaviors and populations related to antimicrobial stewardship. And I have this logo here in the corner because I want to emphasize that a lot of these are very much from a One Health perspective. Some of these are looking at antibiotic prescribing in different sectors of healthcare, such as long-term care facilities as well as hospitals, but others are looking at antibiotic use in dairy farmers, all using the COMBI model. So these are just a small snapshot, but there are literally dozens, if not probably hundreds by now, papers out there that use COMBI as well as other frameworks to do these kind of theory-based behavioral diagnoses. So if you're interested in this approach, it might be worth reading some of these papers for some more examples of how the model has been used to structure questions and in interviews, surveys, or focus groups, as well as what they found. So for now, I'm just going to focus on antibiotic prescribing as an example in healthcare facilities. And I'm just going to summarize some of the factors that come up across these COM-B behavioral diagnosis studies. So regarding capability, a lot of these COM-B studies explore what influences antibiotic use in healthcare, find that healthcare providers, a lot of them actually don't have a significant knowledge barrier in the sense that many of them know what AMR is and they recognize that it is important, that it is a growing public health threat. So that's not a barrier. That aspect of capability is there. However, there are some barriers related to capability. So where there are knowledge gaps are in terms of specific guidelines for appropriate prescribing for different patient groups and conditions. So that can vary quite substantially across care settings and healthcare provider groups. Similarly, and in association, there's sometimes lack of training associated to AMR and antimicrobial stewardship, and lack of confidence as a result in terms of what the best evidence-based practice and recommendation is. There are gaps around clinical microbiology knowledge and incorrect dose adjustment, and also slightly different tact within capability. Some people question the link between antibiotic prescribing and AMR and whether actually prescribing is contributing to AMR, lack of awareness as to what current practice is in their hospital or local area. So are we over-prescribers or not? So how are we doing? Are we prescribing too much or too few antibiotics? What are the rates of resistance locally? So there are knowledge gaps there that make people question the extent to which it might be a problem to them locally and immediately. Motivation, unsurprisingly, is a key influence. So a lot of the barriers that come up around motivation within COM-B is around fear, so automatic motivation. So fear of missing something and potential harm to patients if we do not prescribe an antibiotic. So if we take a more judicious and cautious approach and try to prescribe less antibiotics, might we cause harm? And there's this delicate balance between managing the distal downstream threat of AMR versus the very immediate patient threat and patient need for helping a patient to get better and address the immediate threat. So these are kind of sometimes competing tensions that can cause quite competing motivations and associated emotions. And sometimes not believing that the alternative to not prescribing is as effective, pessimism about the extent to which changing prescribing will actually make a difference. Is it just a drop in the ocean? Are there other behaviors and actors that need to be targeted instead? Plus, healthcare, probably don't need to tell a lot of you, it's a busy context with lots of competing priorities. So sometimes antimicrobial stewardship is just not up there on the list of the various different things busy healthcare professionals need to target. So competing demands and relatively low priority. And then in terms of opportunity, there are very much, unsurprisingly, resource and physical opportunity related barriers. So lack of access to microbiology, sometimes especially not 24-hour, or delays in getting test results from microbiology, lack of diagnostic equipment, high workload, general lack of time means there's no real quality improvement culture because people are just so busy getting on with the day job that quality improvement there's no bandwidth or time for it. And this in turn means that antimicrobial decision-making can become diffuse and uncoordinated. But a lot of the barriers are more within social opportunity. So yes, of course, there are physical opportunity, resource-related barriers, but there's some complex and interesting barriers within how we interact as individuals. So some excellent work's been done looking at culture around prescribing in hospitals, and the term prescribing etiquette has been coined, where there are a lot of hierarchical nature in healthcare, and it's sometimes difficult for more junior staff to challenge the practice of more senior colleagues. So there's this etiquette or culture of not challenging someone's prescribing decision if you might not agree with it. And that can be a real barrier to using antibiotics more judiciously. And sometimes certain roles might pressure or act as gatekeepers. And there's also lots of pressure from patients and family members who may sometimes just want to walk away with something and see an antibiotic prescribed for themselves or their loved one. And sometimes it's quite hard for doctors to manage that pressure and negotiate when someone's seeking an antibiotic. And also variable levels of interest in terms of the extent to which different roles might want to get more involved in antimicrobial stewardship but don't necessarily have the opportunity to do so, to bring together colleagues across different specialties and roles, etc. So lots of social opportunity barriers. And this is not an exhaustive list. What I'm trying to do here is give you a flavor of the types of things that come up within different COM-B domains when it comes to antimicrobial stewardship, specifically antibiotic prescribing. So what you usually find when doing one of these behavioral diagnoses is that there's no single influence on antimicrobial prescribing. It's a complex behavior influenced by an equally complex set of interacting factors beyond knowledge deficits alone. So when it comes to picking potential interventions, which is the next step in the behavior change wheel approach, we need to consider the broad range of intervention strategies and look beyond just education and try to match the choice of strategy to those key barriers that came out in our behavioral diagnosis. And again, we love a framework in behavioral science, and there is a framework that can help you to consider the broad range of strategies and match it to your behavioral diagnosis. And that's where the behavior change wheel comes in as part of this stepwise process. This is the behavior change wheel on the screen here. You'll see that at the hub of the wheel is the COM-B model. So again, the behavior change wheel was developed by integrating different frameworks that specify different types of behavior change interventions, so different taxonomies that were basically long lists of potential intervention strategies and definitions as to what those were. The problem is a lot of these frameworks out there describe the potential intervention strategies you could use, but didn't provide a basis for linking that intervention strategy to influences, so linking potential interventions to a theory or model of behavior. So the behavior change wheel very much has COM-B at its hub. So you move from understanding the behavior using COM-B to selecting strategies. In the interest of time, I'm not going to go through all of the different intervention types. There are 9 broad intervention types, which you can see as the red layer here on the behavior change wheel. And this includes everything from education and training to increase knowledge and skills, but also many other different types of strategies, such as restructuring the physical environment, incentives, coercion or sanctions, modeling, enabling, persuasion, and restricting. You can read this in your own time. There's some definitions and examples of what these are in the broader context. But the key thing I want to take away from this slide is there are lots of different ways to change behavior. These are 9 broad strategies. These can be further broken down into 93 granular behavior change techniques that are defined in a behavior change technique taxonomy. So we have huge potential to try out different ways to change antimicrobial stewardship. And we can do this by doing a behavioral diagnosis using COM-B and then matching that to behavior change wheel to identify which of those potential strategies might best address my barrier or enabler within capability, opportunity, motivation. So COM-B is mapped to the behavior change wheel. So to increase capability, which is all about knowledge and skills, you can build knowledge and skills through education and training. To improve motivation, you can use things such as persuasion, incentives, coercion, and modeling. And to improve opportunity, you can use things like environmental restructuring and enablement. So different types of interventions are better fit to addressing different types of influences. And there are matrices available which pair COM-B with the behavior change wheel, and to help facilitate stepwise progression from a behavioral diagnosis to selecting intervention strategies. So a cell in blue here basically represents a match between a COM-B domain, so a barrier or an enabler, and an intervention type. So based on expert consensus and reviews of the evidence in the literature, if we look at the bottom row around reflective motivation, you might consider education, persuasion, incentives, or coercion as a strategy to address those barriers. So it helps you consider the broad range and then funnel in on potential strategies that are a better fit to the influence, and therefore more likely to be effective. So a lot of those COM-B behavioral diagnosis studies I showed you in the context of antimicrobial stewardship often go one step further and then map their identified barriers and enablers to the behavior change wheel to suggest potential intervention strategies to address those barriers and enablers. So this is just an example. So as we heard, some of the studies found that lack of familiarity with guidelines, poor microbiology knowledge, and incorrect dose adjustments were barriers within capability. That could be addressed through strategies such as education and enablement. And an example of that would be antimicrobial stewardship teams and pharmacists being available to support prescribing decisions and dose adjustment to reduce errors, developing and disseminating specialty-specific guidelines and clarifying indications, or increasing undergraduate and CPD education around antimicrobial stewardship to address some of those knowledge gaps. Moving on to motivation, I quite like this example. So people might, as we heard, think AMR is a general issue, but how much of an issue is it locally? So how much antibiotics are we prescribing? Is AMR an issue locally? People don't often have that knowledge, so they don't know the extent of the problem locally, and therefore motivation to change may be quite low because they might not see it as a personal problem. So something like audit and feedback could be done. So setting targets for antibiotic use based on guidelines, monitoring practice locally, and then providing feedback on current practice, outlining deviations relative to the target can help raise knowledge, but also motivation of current prescribing locally. And lastly, a social opportunity example. If we think about that barrier around prescribing etiquette and junior doctors not being able to challenge senior doctors, something like modeling and enablement, such as senior doctors acting as champions for antimicrobial stewardship, endorsing guidelines, encouraging the challenging of prescribing decisions, having MDT meetings and kind of modeling that behavior can help enable some of those social opportunity barriers. The key thing here is that this table is the opposite of it seemed like a good idea at the time. It represents a very stepwise and transparent approach to intervention design where the solution is matched to the factor that is identified as leading to change. So just before I summarize and wrap up, I just have two final slides I kind of want to go through. I've talked a lot about how behavioral science can be applied to antimicrobial stewardship, but this is a hub on both AMR and digital health. So if I just take a step broader on digital health, COM-B and other behavioral science frameworks have been used not just to design digital interventions, and the design step follows very much the similar stepwise approach I just described. But they've also been used to evaluate and improve the implementation and uptake of new digital interventions. So lots of people have done theory-based process evaluations using models such as COM-B to ask ourselves questions such as, how acceptable are new digital technologies? How are these new digital technologies embedded into day-to-day life and practice? And what are the barriers and enablers to this? And again, here are just 3 studies. They're not from an antimicrobial stewardship context, but they illustrate the approach of how the model can be used to answer these questions in the context of a digital intervention and understanding its implementation and barriers and enablers to that. So this slide outlines some of the different factors that could come up when people do COM-B diagnoses to look at barriers and enablers to new digital technologies. So within capability, there's things like how tech savvy are people in the first place? So digital literacy and technical skills, do they have the knowledge and skills to engage with a new digital technology? Cognitive load, how complex or demanding on attention is this digital intervention? How easy is it to use and set up? And what training or available user guidance is there to support people to use it? But also intervention coherence. Do people understand what this digital tool is, what's its purpose, and what is it trying to do and how to use it? Within motivation, there's things like trust in digital technologies and AI, especially going forward, and any features that offer a safety net around the digital technology are often seen as enablers. Concerns over security, data protection, and ethics, particularly in healthcare, means some people may be more reluctant to use a new digital technology. Perceived need, utility, and benefit relative to an existing solution or a non-digital solution. So is a digital electronic health record really better than a paper-based record? Habit. So often with a new digital technology, we're asking people to stop doing something they may have already been doing with a non-digital solution, break that habit and start using a digital solution. Habit can be quite hard to break. Perceived accuracy, reliability, and feedback, rewards, or encouragement. And within opportunity, there'll be things like cost and accessibility of a digital solution, funding for it, how readily available and accessible it is, time needed to use it, but also particularly in low resource settings, things like electricity and connectivity can be barriers, as well as social factors such as it becoming a norm and peer support to encourage or model use. So the reason it's helpful to assess these things for a new solution is that when you spend a lot of time designing a great digital solution, we have to think about what would it take to put it into practice. So by identifying some of these barriers and enablers, we might identify things that need to be addressed to help optimize and maximize implementation, engagement, and uptake with the digital solution, and help us perhaps design co-implementation strategies to help support the rollout and behavior change in terms of adoption of the digital solution. But it might also help us refine and optimize our digital product or intervention. So to summarize, thanks for bearing with me this far. So human behavior of multiple actors and actions in the system is a key contributor to AMR. Therefore, changing behavior is going to be key to preventing and addressing AMR. Yet, when it comes to designing strategies to change behavior in the context of AMR, they are rarely designed based on an understanding of behavior and drawing on the behavioral and social sciences. These disciplines offer a number of different theories, methods, and frameworks to help us understand behavior and design more targeted and effective interventions. And I've talked you through the behavior change wheel stepwise approach and the different tools those offer, and shown how it could be used in the context of designing interventions to improve antibiotic use. And we've shown that antibiotic use is driven by a complex set of interacting factors related to capability, opportunity, and motivation. So we need to look beyond education and consider the broad range of potential intervention strategies to change behaviors associated with AMR and antimicrobial stewardship. But not just that. As we invest and develop new, exciting, innovative digital technologies, we can also use behavioral science to help us think about how we can best optimize their uptake and implementation in the real world when they are rolled out. So I've given you lots of examples throughout, as well as some initial suggested reading, but as I said, there are loads of amazing published examples using some of these theoretical approaches from the behavioral and social sciences in the context of AMR and digital health. So I have some examples and suggested additional reading here if this is of interest. So lastly, I'd just like to thank you for listening, and here's my contact details and the contact of our centre. If you'd like further information or to discuss any of this, please do get in touch. And lastly, just to thank the EPSRC for funding this Digital Health and AMR Hub.